It's snowing? Is it snowing right now? Oh, awesome. Yeah, it's supposed to snow. They said like 1 to 3 inches tonight. Tomorrow. And the good news is we don't have school tomorrow. I mean, we don't have my class tomorrow. That's the one I worry about. Don't tell your other professors I said that. You don't have my class tomorrow. Okay. Is this on? Check, check. Can you guys hear that? Hello? Is that on? Check, check. Can you guys hear that? Okay. What happens to a frog's car when it breaks down? Gets towed away? Needs to get towed? I like that. What did the duck say when he bought lipstick? Put it on my bill. Well done. Did you guys hear about the kidnapping at school? It's okay, he woke up. Wow. We're like, it's a little scary. That's a little... So, you know what I'm going to point out is, like the first day of class, you guys were not into this, just so you know. Like, look at the video. It's like, wah. No, I'm just serious. It's like, wah, wah, wah. Like I say a joke, and you guys are like, what? What is happening? Who is this guy? So these are just icebreakers. Now you guys are into it. So funny. You guys were totally not into it. Okay. Any questions before we get going? All right, our task is to finish out inflammation today. And we're going to talk a little bit about biomaterials at the end because I'm going to weave it into another aspect of inflammation that is associated with medical devices, okay? So that you guys can see that inflammation is broad-based. I mean, it's in all sorts of different places. And like I said in Monday's lecture, this lecture is probably the one that I think may be the most valuable for the longest period of time in your career. Because what we learn in the inflammatory section is foundational for so many different types of diseases, so many different types of clinical situations. And inflammation can be caused by something going wrong within medical treatment or medical practice. And so at the end of today's lecture, we're going to talk about biomaterials because it's a great way to give an example of chronic inflammation. And I'll tie it back to that cobalt chromium hip implant that we looked at last week. So, whoops, let me find it right here. You guys remember this? So I kind of fast forwarded a couple of slides because I wanted to end on sort of a high note. And so we're going to back up a tad, and we're going to back up to this slide because I want to remind us of the different stages in inflammation. So inflammation is normal. Acute inflammation is important. It's part of the normal wound healing process. If you don't have it, you can't actually heal. So, for example, if you completely obliterate inflammation, you'll get into a state where the tissue won't go through a healing process. And that's what broad-based, large anti-inflammatories do, like corticosteroids. So if we do a corticosteroid treatment for somebody, usually it's big dose and then you taper off because it blocks inflammation altogether. And inflammation is the first step in the wound healing process. So we drew this graph last time, and we saw this peak that I talked about with acute inflammation. And if this is wound healing, if this is a graph of wound healing, I actually put it up here. Different color, yeah. Let's just start all over. How's that? think I can. There's red, but that may not be. I think I got some. Hang on. Oh, look at this. I got black. You got one? Is this better? Okay. So if we've got time on the x-axis and we look at healing, we're going to see inflammation as this first peak. And the cells that move in here initially are neutrophils. They're the first cell type that comes in on the scene. And then after this peak, we're going to see a second peak of inflammation, and these are macrophages. And this is the symbol for a macrophage, the nomenclature. Okay? But what's important is these peaks come up and then they come back down. And those two peaks typically trigger the body to say, okay, I'm going to go through this healing process. So if you don't have those two triggers, you don't initiate healing. Now, I also kind of alluded to on Monday that when it becomes problematic is instead of dropping down, either of these stay elevated and they persist. And these dotted lines over here, those mean chronic. And we'll look at comparing and contrasting the two different types, acute versus chronic inflammation. And we'll give some very specific examples that one could write test questions about, okay? And then we'll characterize it in that way. Okay? So this is how I think when I write exams. I'm like, all right, well, how about a test question on the difference between acute and chronic inflammation? Like, what are some things that you see in acute inflammation that you don't see in chronic, and vice versa? Okay? It's not rocket science. It's part of every class is kind of understanding, like, well, how does the professor decide to write test questions? Like, what makes them think? And that's always kind of the hardest part about the class is figuring out the faculty member. That's why you got an interpreter. You got an SI who's already taken this class, did really well, and already knows my little idiosyncrasies. And every faculty member is weird, myself included. We all are a little bit off, okay? So you got to figure out how are we thinking and what are the kind of questions that we're going to ask. Okay, so now let's talk about these macrophages. The whole goal here is to recruit these neutrophils and then macrophages, okay? So we're getting in these leukocytes, and now we understand the mechanism by which we're going to get those leukocytes to the tissue. Because if they just stay in the bloodstream, they're not going to do any good. If they extravasate, or if they diapedese, right, they transmigrate across the endothelial wall, they utilize integrins to firmly adhere, they utilize selectins to lightly attach and trigger this rolling process, and they have eventually, prior to that, marginated to the edge so that they could find the selectins, but the goal is to get them out into the extracellular matrix here so that they can chemotax all the way to the location of injury. What are they going to do there? Well, they're going to phagocytose particles, debris. That's what they do there. So now we're going to look at how they phagocytose debris. So this is a phagocyte or a macrophage. It's been recruited to an area of tissue damage. It's wound up, it's stimulated, it was woken up, it had its coffee, and now it's ready to act and work. And so this is its membrane right here up top. And this membrane has these receptors which are called toll-like receptors. That's the category of receptor, toll-like receptor, or TLR. And these toll-like receptors are going to recognize and bind the microbe. This little orange pill-looking structure is the artist's representation of a microbe or a foreign object. It binds these, and then it zips up around the microbe, or it engulfs, it invaginates, okay? It internalizes this, and then this pinches off, and this becomes a phagosome that's got a bacteria within it. or damaged tissue, or it has a virus particle, it has debris. In the case of this bacteria, this microbe, you've got other vesicles inside the cell that have enzymes. And now they fuse and you form this phagolysosome. And those enzymes can help to degrade the microbe or break it down, or they can degrade the particle of necrotic tissue that you're trying to clean up. If the microbe is resistant, or that's the wrong word to use, if the microbe won't degrade with conventional methods, like with enzymes, then it has to use free radicals. And so this is the membrane of the phagolysosome. And inside this membrane, you've got this oxidase molecule. And this oxidase molecule takes oxygen and it manufactures a free radical, a reactive oxygen species. This is happening, though, in the safe confines of this phagolysosome, inside this compartment, so that it's not outside in the cytosol causing problems to the cell. It's contained within this phagolysosome. So that's what's going on right here. This free radical kills the bacteria. It's harmful. So Monday we talked about reactive oxygen species or free radicals causing tissue damage, right? And how that's a problem with injury. Well, I told you, if you look back to the lecture, we're going to foreshadow to where we can use it to our advantage as a tool. So it's a weapon here against bacteria, and that's how you can actually kill the bacteria. This process is called the respiratory burst because it's using oxygen. So you're taking oxygen through this phagocyte oxidase, you create a free radical, a reactive oxygen species, and this respiratory burst mechanism is what you use as your weapon against microbes that you find, or the phagocyte finds. Is that all clear? Now, we've all heard of this. Okay, so someone got sick, and they gave them antibiotics. They gave them a course of antibiotics. They did really well for like the 7 to 10 days. And then as soon as they came off of the antibiotics, the infection came back. Right? Now they're on their second round of antibiotics. So what's going on there? Well, in certain circumstances, you'll have bacteria that are resistant now because they've mutated. So we have resistant strains. And these resistant strains may not respond to just reactive oxygen species, which is our intrinsic way of dealing with bacterial infections. And so when it gets out of control, now these new strains require us to have exogenous forms of antibiotics in order to get rid of them. In addition, if the number of bacteria that are present population-wise are too much of a demand for the ability of this respiratory burst mechanism, then the bacteria win and the macrophages lose. Okay, so from a battlefield standpoint, if you have a lot of bacteria that are winning and macrophages that are losing, you'll actually lyse this macrophage and you're going to dump its contents because the bacteria will kill the macrophage. And so what is that going to do in your mind to the surrounding tissue when the bacteria win and you've got lysing of the macrophage that had a bunch of bacteria inside of it, and it created all these free radicals that were contained in this phagolysosome, but now where are they? They're in the tissue, and now they're causing what we characterize as less desirable effects. Okay? So we use it as a tool to combat the bacteria, but sometimes the bacteria win, and we've all seen situations like that, and this can cause bigger problems if it's left unchecked. Okay, so the question now is, and this is a key point to link, because this is kind of the inflection point between when inflammation is a good thing and when inflammation becomes a bad thing. So these leukocytes can damage tissue. You've got a circulating monocyte, which is a type of leukocyte, It adheres, it immigrates out. This is just a picture from a different textbook. Now it becomes a tissue macrophage, and it can become this activated macrophage. And what's common in drawings and books is the monocyte kind of looks clean. The macrophage has these vesicle, these dots, because the macrophage with all of these yellow dots, it's characterizing all these lysosomes with these enzymes. So now you've got sort of this freckled monocyte, which is depicted as a tissue macrophage. When it becomes activated, it's hair spikes. That's kind of what I think. Like, so you see how it's ruffled on the borders? Now it's activated, and there's a huge difference between an activated macrophage and just a senescent or a quiescent macrophage. And so this one is activated, and in the activated state, it's got a whole list of things that can stimulate tissue injury, and it's got a whole list of things that can stimulate fibrosis. Okay, so what's fibrosis? Scarring. That's the simplest translation. Okay, so tissue scarring. So here, you take your activated macrophage, the toxic oxygen metabolites that are toxic to the tissue, that's what we just talked about right here. It's talking about this respiratory burst. So that's the toxic oxygen metabolites. Well, there's a lot of enzymes that are within those lysozymes, and so those proteases get dumped out too. And those enzymes can start digesting the extracellular matrix in the surrounding tissue and cause more damage. And then the list goes on. I mean, these are kind of like, here's a perfect example. Like, so I'm showing this slide, and the stuff that I'm choosing to focus on the slide in lecture is tissue injury, oxygen metabolites, and proteases. I'm not going into great detail on all the other list of things that cause, bless you, tissue injury, okay? So you can kind of anticipate, well, he's really kind of focused in on free radicals that are coming out of macrophages because we've had 2 slides on it now. You with me? And we also had 2 slides that characterized these proteases. And he mentioned all the other list of things like neutrophilic chemotactic factors, coagulation, all these other ones, but he didn't spend a lot of time on it. So if you've got time to study, you may be focusing on this slide that generates the respiratory burst and the oxygen metabolites that kill the bacteria, and then it gets bad if the bacteria win and it lyses the macrophage, and that can cause tissue injury. So I'm just trying to give you some tips on how to sift through all of the information and focus on the stuff that we highlight. All right, over here in the fibrosis category, let's talk about scarring. So the scarring are a lot of growth factors. And growth factors are chemical signals that tell cells to do something. So they'll either tell them to proliferate or divide. They'll tell them to migrate. They'll tell them to make more extracellular matrix. These growth factors will give them all sorts of signaling cues on what to do. And they're not all bad. It's just if there's too much of them in a certain circumstance, they might be pushing the remodeling into a scarring formation versus non-scar. So all fibrosis or a scar is an overabundance of deposition of new tissue that's organized differently than the original tissue. And so it doesn't have the same tensile strength. It doesn't have the same mechanical properties. It doesn't feel or behave the same. But it's kind of like spackle on the wall to cover the hole. So your body is defending itself by filling in the gap of damaged tissue, but it's doing it by releasing these new growth factors and cytokines, which is just another name for chemical signals, that cause new tissue to be deposited, but it's going to have a very different consistency than the original tissue. So another analogy is like, you drive down the Flagstaff Road right now, and you cannot avoid hitting a pothole, right? And then sometime in the summer, all those potholes most of them will be filled. But you can tell exactly where they were. And sometimes the pothole filling was better than other times, right? So you're driving and you hit a bump and your coffee goes, and you're like, that was a pothole. And your friend's like, no, that was actually the repair. It's a speed bump now, right? So you know that the original repaired or the newly repaired tissue doesn't resemble the original. Okay, that's fibrosis. So we've got things like platelet-derived growth factor, fibroblast growth factor, transforming growth factor beta. These are all signals that trigger cells to reproduce or multiply, proliferate, and migrate. Then we've got angiogenic factors. They stimulate new blood vessel development. So if you're going to repair a tissue, it has to be oxygenated. And so it's very important for you to bring in a new blood supply to bring nutrition to the remodeling tissue and to remove waste products. Okay, so angiogenesis is very important. And then remodeling factors. The remodeling factors stimulate new collagen deposition. So the main extracellular matrix protein in our tissues is actually collagen. There's 23 of them. There's 23 different types of collagen. And mostly you hear about collagen 1. But this new collagen deposition in, let's say, for example, in skin. So in skin, you have collagen 1 and you have collagen 3. And when you are being made in the womb, you have a certain ratio of 1 to 3. And then that's embryonic collagen deposition. And then as we age, the ratio flips. And so when you're an adult, when you heal, your 1 to 3 ratio changes, and you have more collagen 3 than collagen 1. And so the new collagen that's being laid down of collagen 3 over collagen 1 looks different than the original collagen. And that's why you can tell, because it's a different type of collagen. Okay? But laying down collagen is important. And so that shift from collagen 1-3 ratio, that slowly happens in our pediatric years. So right about puberty, something magical with puberty tips it over where, that's why I was saying, earlier in the semester, if you had a cut when you were 5 and it healed, it probably healed really well. If you have a cut now that you're post-adolescence, it probably won't heal as well. Newsflash, as you get older and you have healing that needs to happen, it gets worse. Okay, like the scarring gets more aggressive as we get older. Okay, so the closer you are to embryonic collagen deposition, the more original the tissue looks. And the further away we get from that, the more fibrosis happens. Okay, so leukocytes damage tissue using these reactive oxygen species, and this leads to this fibrosis that can take place because of all of these metabolites that leak out. So we talked about these two slides, and this is my representation of what happens in the first few days that I drew for you. So you can kind of appreciate day 1, day 2, day 3. So the first bar is the fluid, which should make sense based upon what we talked about previously. So let me add that to my graph for sake of completeness. Right, and we'll call this fluid. And that's from transudates and exudates, right? That's the first step when the blood vessel vasodilates, and now you actually have a permeable vasculature, and you get the leakage of fluid, and you get the leakage of proteins. So that happens almost immediately. You sprain your ankle, it starts to swell. And then within the first 24 hours, you get infiltration of neutrophils, the first cells on the scene. And then about a day or two after that is when you have this peak of monocytes and macrophages. And these are the first 3 peaks or bars that happen that trigger the healing response. Pretty straightforward? Okay, let me look at my notes here. Questions? Yes?
So you said it's like they release the macrophages, release the content into like the tissue and stuff, and it's really bad because it loses all this radicals and everything. If it's so bad, then why do they do it?
So the macrophages releasing their contents into the surrounding tissue?
Yeah, so why do they do it if it's so bad?
Well, so that only happens if the macrophage gets compromised. So under normal healing situations, the macrophage will go phagocytose. It'll neutralize the bacteria, okay, and nothing gets dumped out. The only time things leak out is if the macrophage dies. Does that make sense?
Yeah, but why would it release it instead of just the common life that might be toxic?
Well, it's not alive, so it doesn't get a choice. So it's killed by the bacteria, and so it doesn't have a decision in what it can do at that point in time. So it's actually the bacteria's fault. I agree with you, it's not favorable that happens, that it leaks out its contents. But unfortunately, that goes with the territory because it's pretty contaminated with bacteria. So if it wins, it's a good thing. If it doesn't win, then it becomes a problem. Other questions? The macrophage? Well, I mean, well, no, pus will happen when it's a chronic infection. Yeah, so, I mean, it's not really that the macrophage dies from overeating per se, but if the bacteria takes over, it could become a problem. And so pus is cellular debris, right? That's what pus is it's lysed cells and cellular debris. So anytime there's pus, that's because there's a bacterial infection where you've got carnage, right? Some macrophages have lost, some macrophages have won, but now you've got debris and cellular contents. I try to explain to my kids to not pop their pimples because you're just, letting all of this cellular debris all over the mirror, right? And then it looks gross. So that's all pus is cellular debris. All right, let's characterize different types of inflammation from more of a gross or macroscopic perspective. So on this section, we're going to talk about serous, fibrinous, suppurative, and ulcer. So serous inflammation is associated with a watery consistency. It's protein poor fluid, where most of the effusion is a fluid that's trapped into a cavity. So on a serous effusion, the example that you could write down here is a blister. Okay, everyone's had a blister. So a blister, if you pop a blister, it's a watery fluid. There's usually no blood in it. There's very little cells. It's mostly water. So that's a serous inflammation response. Fibrinous. This happens with more extensive injury. You have greater capillary permeability, so you're not just getting fluid out, you're also getting protein like fibrinogen, so fibrinogen exits, and this can become fibrin and allow for a clotting network to take place. You see fibrinous inflammation in a lot of body cavities that are inflamed. So the upper right picture is a fibrinous pericarditis. So this is over the heart. So this is the heart underneath, and this is the pericardium that's been cut away. This is a pair of pickups, or tweezers as you would call them, and it's reflecting this flap away. And what you're looking at is fibrinous pericarditis on this side as well as on the surface of the heart. So what are we looking at? Well, the white glistening areas are what it should look like because it's a serous membrane. It's an epithelium that should be glistening, and so that would be the white part. The yellowish kind of orangish color is the area that's inflamed, and you can kind of see a yellowish tone on the surface of the heart as well. Suppurative. Suppurative is usually when you've got an infection, like what we were just talking about. You get pus. The suppurative infection Acne would be an example of that, but more pathologically, we would talk about like an abscess. When you have a tissue abscess, you get significant exudates that come from neutrophils or cellular debris. Some of them are dying and lysing, and they're dumping their contents, and there's a local accumulation of pus, and we call this superlative in an abscess. Much of the content within the pus are necrotic cells or dying cells, and a lot of endemic fluid, like fluid that's coming out because of the increase in vascular permeability. And then lastly, we've got an ulcer. So an ulcer is an erosion that takes place of an organ or a tissue surface due to the shedding of necrotic cells. And this lower left picture is an ulcer like what we saw with the duodenal ulcer in the very beginning of the semester. And so this is in the duodenum or the small intestine, just like what we were talking about before. The superlative, another name for it is purulent, and this is a purulent infection on the lower right, or a superlative infection on the lower right, where we've got the neutrophils and cellular debris that are accumulated in the middle. This is where the pus would be located, and then all of these peripheral red branching networks are all the vascular tree that is vasodilated in the inflammation and allowing for a lot of the edema to flow in to this purulent or suppurative infection. Okay, so we've got fibrinous upright, we have ulcer lower left, and then we have purulent or suppurative lower right. And I don't have a picture of a blister, but I'm imagining everybody knows what that looks like. So what can happen? What can happen in these infections? Well, what can happen with inflammation? It can become infected, but not always. And so we've got a couple of different progressions that can take place. So here is the vascular network. That's what this is a diagram of. So we've got our arterial side on the left, we've got the capillary network in the middle, and then we've got the venule side on the far right. And this is dilated out. This is vasodilated out. And hopefully you can appreciate there's a lot of neutrophils that have been recruited into the surrounding tissue. So these are all neutrophils that are recruited into the area, and now they're considered what? Tissue macrophages. Very good. So these are all tissue macrophages that have left the vascular network because of these vascular changes. And you can see the injuries that would result or cause this are things like an infarction, right? Like you have a myocardial infarction of the heart, you have a kidney infarct, okay? Bacterial infections, where you want those macrophages there to kind of clean up and kill the bacteria, hopefully not die. The plan is not for them to die. Toxins or trauma, okay? All of this would cause this situation. Ultimately, this should resolve. You should reach resolution, where you're going to have angioregression, meaning that the vascular tree is going to shrink back down. You're going to have clearance of the cells. Everything is going to go back to normal. And with resolution, you've got return to normal function. This is ideal. This doesn't always happen. Okay, so that's one category, or one direction we could go. Another direction we could go is we could go from acute, we could heal, and it doesn't return function, but it heals, and we lay down new collagen, and there's a fibrotic response, and that's scarring. So we have a loss of function because you replace the original tissue with new tissue. And so like in the case of the heart, if you had myocardium there, myocardial cells, and you replaced it with collagen matrix, it's not going to be contractile anymore. And so you have a scar on the heart, which is a coagulative necrosis or a myocardial infarct that's classified as coagulative necrosis, but it's not going to contract. So you've lost the function. So that's one option. This is called a healing, or what we refer to as wound healing, no matter where you are. But the key difference between healing or in resolution is that you have a return to function with resolution, and with fibrosis or with healing, you don't return the function. You just sort of fill the pothole, or you put spackle on the nail hole. Okay, up front and then in the back.
What would cause something to, instead of go completely all the way to like resolution, just heal to fibrosis?
Yeah. So the question is, what would trigger it to go this direction of healing to fibrosis versus this direction, resolution? Great question. We're going to talk more about this next week, but I hate when professors do that, like they don't want to answer the question. So the answer is the extent of the injury, number one, how much infection there is, number two, and then if it's trauma, like how clean the injury is. Like, what do I mean by clean? Well, and let me pick. So, if you've got tissue trauma where you've got jagged edges like this, right? This is one side of the tissue, and this is the other side of the tissue. You're going to get a lot more scarring. If you have injury where the tissue looks like this, you're going to get far less scarring. Okay? So, I mean, it's very simple, but it's a great question. If there's bacteria, then you've got more work to do. And you're going to have to kill them. There's going to be more cellular debris, and so it's probably going to favor more fibrosis. And I'll tell you this, it's usually not one or the other. It's some sort of blend. Okay? When we're younger, it's much easier for resolution to occur. As we age, we get a lot more fibrosis. So age, and that should make sense, age is a disease. And so as the disease continues and we get older, your ability to do this up top of heal well with resolution and complete return to function is compromised. But there's still some more stuff here. So this is just two great questions. Oh, Max, you had a question.
Could you use like stem cells or like, especially for like the heart, that's really vital organ, and I don't want fibrosis in a patient. I want them to have normal function.
Yeah.
And like layer it, take out tissue that's trying to keep fibrosis and layer it with the
Yeah.
layer of tissue that's
Yep.
helping you with
Yeah.
that improves the percent function.
Yeah. So the question is, can stem cells be instituted in these kinds of situations? And there's a lot of popular press now about stem cell therapies. So the answer to your question, generally speaking, is yes. In animal models, we've got some really impressive data as a field. Not just me, but like the field in regenerative medicine. When it moves to the clinic, it's more variable. And so a lot of great rodent and mammalian work, and then they get over into clinical trials, and it doesn't really translate as well. So for stem cell injections into cardiac tissue, for example, that's absolutely been happening. And I've actually been engaged in a number of companies that's been our mission, and that's what we've done. But where the difficulty happens is in the human model. It doesn't work nearly as well as it does in laboratory models. So we're still trying to work out those details. But the power of the progenitor cell is there. Like the ability for the stem cell to promote healing, it's there. It's just a matter of, I think, humanity kind of catching up with the capability of the biology. And we just don't know how to control it as well as we think we do. Okay, let's talk about this line here, if it progresses to chronic inflammation. This is where we're headed later in the lecture. So, in chronic inflammation, the injuries never go away. That's the key. Is the signal for tissue injury never subsides. So, chronic inflammation of the esophagus. We looked at that in the beginning. What was that? It became eligible for an esophageal adenocarcinoma. What was the disease? Barrett. Yeah. So the Barrett esophagus. Why am I calling it chronic inflammation? What's the injury stimulus that never went away? It's the hydrochloric acid. It's chronic. It's always there. And so now you've got this vascular network that is dilated. You've got all these tissue macrophages that are present. You've got remodeling that's taking place. So you've got mononuclear cell infiltrate. That's a fancy word for saying you got a ton of macrophages, right? So you have a lot of macrophages that are there. We know macrophages can stimulate scarring or fibrosis. So that's what you're seeing with chronic inflammation. And you get this angiogenesis because you're trying to heal the tissue. And macrophages dump out a lot of angiogenic growth factors because the macrophage is saying, well, I'm going to try to heal this tissue. I need to increase the vascular network to bring in more nutrition and remove metabolic waste products as we kind of heal. So that's why this is happening. So viral infections, chronic infections, persistent injury, and autoimmune diseases all have underlying chronic inflammation associated with them. So this is the category that we'll be pointing to much of the semester, is chronic inflammation. Not necessarily acute inflammation where you need it to heal a wound because it's a defense mechanism. Hopefully what you can understand is this is how it's supposed to work. Here to here, maybe here to here. This is kind of the way your body is designed. This is a pathological state. But we have to understand how it normally works so that we can compare it to what happens when it goes awry. So chronic inflammation is truly the pathology, and acute inflammation is really more normal physiology. And one could argue, depending upon how you want to argue, well, Keller, is fibrosis pathologic? Say, well, I guess technically you could make an argument that it is because it's worse with age. Okay, it's really not supposed to scar. It's supposed to resolve and have normal function. As we get older, we lose that ability, and age is a disease. So, yeah, I could see your point. Maybe this is a pathology. Then the other student may say, well, no, I disagree because these two are part of the normal process. If you don't close up the wound site and cover it, you leave it open for more infection. So this would be kind of part of your defense mechanism. So both of these are considered normal physiology. Okay, fine. No one's going to argue here. Is this pathologic? Absolutely. Do you see what I'm getting at? So kind of it depends about, this one's kind of, I'm not sure, we can go either way. This one's pretty clear. This one's pretty clear. Okay. Last one on the screen, and then I'll take some questions. This is sort of an intermediate phase, just kind of characterizing what happens with an abscess, because we were talking about abscesses on the last slide. So you get a lot of macrophage activity, and it's trying to clean things up, and it does, but because there's such a burden, you get a lot of lysed, compromised macrophages that don't make it. They fight the good fight, and they die. And that's where a lot of the cellular debris comes from, is these leukocytes that sort of fought the good fight but didn't make it, okay? And so that's where a lot of the abscess takes place, and eventually this tends to resolve into a healing response. But when you get an abscess or a lot of pus, you get more fibrosis. So that was another, part answer to the original question is, this will happen if you have more of an infection, like you've got pus formation, okay, or a purulent infection. Okay, there's another question.
Well, I was just going to say for fibrosis, wouldn't like the body say, okay, you know what, this isn't going to function, even if you try to do it, it's probably going to get infected again, so we're going to change the composition of what we have over here, that way it won't get infected again. Maybe that could be what happens.
Yeah, I mean, really, it may not be that sophisticated, and here's why, is because at this state, you don't really have the ability to create the native architecture. So, for example, there are certain organs that do. So, for example, like skin. Skin heals really well as an organ. Liver heals really well as an organ. Heart, not so much. Kidney, not so much. Bone heals really well. I mean, you guys, if you're athletic, even recreationally athletic, and you get an injury and you go in, and you've probably heard this. Well, it'd be better if it would have broke, the bone would have broke versus the ligament strained, and you know what I mean? Because bone heals really fast, really well. Bone's pretty easy to work on. Ligaments and tendons don't heal very well. And actually, one of the reasons for that, this is alluding to next week, bone is extremely well vascularized. If you cut bone, it bleeds like crazy, like surgically. If you go into a surgery and you cut into bone, it's hard to get it to stop bleeding. Tendons and ligaments are not well vascularized at all. Cartilage, not well vascularized. In fact, some surgeons say that it's avascular, right? It's without vascular altogether. So if you tear tendons, ligaments, or you rip cartilage, the chances of it healing are very low. And if it's going to heal, it takes forever. Whereas if you fracture a bone, 8 weeks later, you're walking on it, and you're PT and you're back at it, and, you might have some atrophy of the muscles that attach to it. But usually in athletics, like a bone fracture is far preferred over tendon, ligament, or bone. So blood brings a lot of these healing attributes. So if you think about the importance of inflammation and you think about a non-vascularized tissue, like cartilage, and you tear it, or ligaments or tendons, how are you going to get all of these cell types there if there's no blood supply? So that's a perfect argument to support the statement that I made of, inflammation is key. Well, inflammation comes from the vasculature. So tissues that are avascular don't heal well because you can't recruit these cells that you need in order to promote healing. Okay. Chemical mediators. So we're getting into some mechanistic slides here. And these are pretty important. They look egregious, but they're not horrible. And so we'll walk through them, relatively methodically. Well, we've got chemicals that are going to be signaling agents. That's the way to think of these. These are signaling agents. And we've got a couple of different sources of where these chemicals come from. And I've told you a lot of them come from these macrophages. And that's true, although not all of them come from the macrophages. So we could have, at the site of inflammation, we have injury to cells that can release some of these factors. We've got the macrophages in the form of leukocytes, and they can actually have these chemicals that are either preformed, they've already been manufactured and packaged, and they're packaged in these nice little containers known as vesicles, or they can manufacture them from scratch. That's what the word de novo means. That means they make them on demand. Okay. And then lastly, we can have factors that are involved in inflammation that are circulating in the blood because they're in the plasma. So let's work backwards. Let's talk about the plasma one first, okay? So the liver makes a tremendous number of proteins. It's one of its big functions. I mean, it's a filter, but it also manufactures a lot of proteins. And these proteins are released into the plasma. So not on the screen, but a critical one is albumin. So albumin is manufactured by the liver. Albumin is it's one of the largest proteins that are found in the blood. And blood albumin never leaves. It stays within the blood vessel. Blood albumin alone is one of the major contributing factors for coiloid osmotic pressure that allows for fluid to come back into the bloodstream and not be out into tissues. Otherwise, we'd have all this swelling. Okay? And clinically, and we'll see this later in the semester, clinically we have patients that have liver problems and they don't make enough albumin. Guess what? They have a lot of tissue edema because the fluid that's supposed to be in their bloodstream isn't reabsorbed because they don't have enough albumin inside their blood vessel. So, liver is very important in manufacturing proteins like albumin. Here we're talking about complement and we're talking about factor 12. Now, complement is named such because scientists sometimes aren't all that creative. It complements inflammation. These are molecules that are manufactured by the liver that help complement the inflammatory process. So we name them complement. Makes sense, right? So we'll look at these C3A, C5A, C3B, and C3B9 here in a second. So just hold that thought for a minute. Then factor 12, the Hagman factor, this is involved in the kinin system and the coagulation system. And we're going to look at that here in more detail in a second. Okay? But the summary here is, and the importance of factor 12 is, remember when we talked about margination? Like that's the first step of recruiting these macrophages. And I talked about having a controlled coagulation where you slow down the blood and then the cells migrate to the edge where it's slower. Because if they stay in the middle, the blood velocity is faster. So you kind of control, don't clot it so you just block all blood flow, but you make it a little bit thicker, like syrup. You increase the viscosity of the blood, and then the cells kind of marginate. They move to the edges where it's a little bit slower. And factor 12 triggers the coagulation cascade. So it would make sense that the liver is playing a role in inflammation because you have to recruit macrophages. Okay, let's back up here to this slide, or this portion of the slide. Cellular derived. Now, preformed, already packaged in the vesicles in the cell, we've got histamine and serotonin. These guys are potent vasodilators. Histamine and serotonin. Potent vasodilators. And we all now know that vasodilation is an important step in inflammation because it dilates the vessel. It allows gaps to occur between the endothelium so that there's a pathway for which these leukocytes can migrate out. You can see the sources of cells that they come from: platelets, mast cells, basophils, and platelets, all found in the bloodstream. And then newly synthesized. So we've got prostaglandins, leukotrienes, reactive oxygen species. These are the sort of the three that I'm going to focus on newly synthesized because we're going to touch on them in great detail. All leukocytes manufacture prostaglandins, leukotrienes, and reactive oxygen species. And you know that reactive oxygen species can also be made by tissue macrophages, but that's a form of a leukocyte, right? Okay. So this is where we get all of these tissue mediators from. Now let's talk a little bit about what they're doing. And I have a summary slide at the end of this little section to kind of help us study, because there's a lot of information on the next, like on these 3 slides, there's a lot of information. So let's take a look at a de novo, like from scratch, something that we manufacture. So what is this? If we back up to this slide, we're going to be looking at prostaglandins and leukotrienes, for example. You're like, what? Where's that? Well, here's where leukotrienes are, okay? And here's where prostaglandins are. But I'm going to add a little bit to that list that was on that prior slide. And here's what we're going to add. We're going to add leukotrienes. So we have leukotrienes. We're going to add thromboxane, prostacyclin to the list. So we've got prostaglandin, prostacyclin, thromboxane, and leukotrienes. Okay, 4 that are manufactured from scratch, that are made, and they're involved in inflammation. So let's walk through this. All of these products, leukotrienes, thromboxanes, prostacyclins, and prostaglandins, all tree up to arachidonic acid. You guys follow? So arachidonic acid is the precursor that gives rise to the family of prostaglandins, which gives rise to prostacyclines and thromboxanes. Arachidonic acid is the precursor that gives rise to the leukotriene family. It's almost like a family tree. If you back up from arachidonic acid, where does it come from? It actually comes from fat, phospholipids, that are derived from the cell membrane. So here's what the cell does. These compounds, leukotrienes, prostaglandins, prostacyclins, thromboxanes, they're in a family of compounds known as eicosanoids. Eicosanoids. Okay, so your book's going to talk about eicosanoids. These are the 4 eicosanoids that I care most about. The cell is going to say, all right, I need me some eicosanoids. Where am I going to get them? Well, I've got a lot of phospholipid in the membrane. So I take a little bit of phospholipid, I digest it with phospholipases, that's an enzyme that breaks down phospholipid, and I make arachidonic acid. And then arachidonic acid, through cyclooxygenase makes my family of prostaglandins, which leads to prostacyclines and thromboxanes. And arachidonic acid through 5-lipooxygenase manufactures my family of leukotrienes. That's where I make these from. I make these from the cell membrane. Pretty straightforward, right? What do? Well, look at these little boxes. We've got the leukotriene family. Increases vascular permeability. These eicosanoids are found all over the body, so they have multiple activities. So focus on highlighting increased vascular permeability. Is that important in inflammation? Yep. Does that make sense? Yeah, it should make sense. Okay. What about causing vasodilation over here on the prostacyclin family? Does that make sense for inflammation? Causing vasodilation? If you promote vasodilation, are you allowing for the inflammatory process to continue? Yeah. Okay. So the natural question is usually, well, why do you have vasoconstriction being stimulated here and here? I understand vascular permeability and I understand vasodilation, but why vasoconstriction? Any ideas? Yes, sir. In and out faster? Okay. Like on the wind it up phase? Okay. Any other ideas? Is it for tissues that don't need blood? Usually this is only happening at a local level. Okay. Oh, okay. Yeah, is that what you meant? Okay. That's a good team effort. Sorry. Sometimes it takes two of you to communicate with me. It's a little thick in the head sometimes. Okay, so yeah, so the idea is, well, maybe the vasoconstriction is happening more peripherally, and then in the area of interest is where the vasodilation is. Yeah, that's a good answer too. So, right. Yeah. 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 So it is a regulatory step. So for example, if the only thing that we do when we trigger arachidonic acid and inflammation is vasodilate and increase vascular permeability without any regulation, we're going to be in trouble. Okay, so it does regulate. It may regulate like on the periphery of the tissues, but it also regulates in that local area. You don't want uncontrolled vasodilation happening. You don't want uncontrolled increase in vascular permeability. So you have some regulators to kind of control and keep in check how aggressive this response gets. Because if you vasodilate without any controls, you could actually have way too much volume of blood leaving, okay, and you have, hemorrhaging taking place. So consider these regulators. Okay, so a couple of important pieces on this slide, just to reiterate, and then we're going to talk about two more things. These are eicosanoids. There's 4. Prostaglandins, prostacyclins, thromboxanes, and leukotrienes. They all have a role in inflammation. Some of them increase vascular permeability and cause vasodilation, and others have regulatory components that are important as well. The cell manufactures these eicosanoids when they're needed, and they do this from the cell membrane, making an intermediate of arachidonic acid that they use phospholipase to create. So, if I want to block inflammation aggressively and cease vasodilation and vascular permeability from going up, and therefore lower inflammation, where on this tree would you block? Higher up or further down? Higher up. So, corticosteroids are potent anti-inflammatories, and they block the activity of phospholipase. So you never manufacture arachidonic acid. If you never manufacture arachidonic acid, You don't get any eicosanoid production. Make sense? So corticosteroids as an anti-inflammatory are very effective because they're operating way up top. Now you can see there are some other ones like aspirin or COX-1 and COX-2 inhibitors, which do have anti-inflammatory activity, but they only act on cyclooxygenase. They leave lipooxygenase open to have its ability to increase vascular permeability. So you have less of an inflammatory block with aspirin or a COX-1, COX-2 inhibitor, and a steroid is a broad-based anti-inflammatory. Does that make sense? So some of the rationale, the pharmaceutical rationale for the future physicians and nurses and any healthcare workers as to why, all medications are not created equal. It's important that you understand some of the pharmacology because you don't want to give steroids to everybody, okay? It's not a good idea. Like, you obliterate inflammation, which is the word that I always use. Like, if you want to obliterate inflammation and prevent any opportunity for any sort of healing to take place, then steroids are your choice. But I don't think that's what we want. Not in all cases. Sometimes it's necessary. Okay, let's go back to our complement, and then I'm going to wrap this up with a slide that talks about a summary of this little component. Yes?
When we go back to the other slide, I don't understand how acid can do all that. I always think acid is bad. The acid things down. So I don't understand.
No, so arachidonic acid is not necessarily like acid or a base. It's a compound. Arachidonic acid is a compound. So it's a precursor it's called arachidonic acid because it has an acid component group on it, but it's not like a liquid acid like what you're thinking. It has an acid group on it, but it wouldn't necessarily be like a hydrochloric acid. It's a carbon chain molecule that actually has a configuration that looks like a spider, which is kind of where it gets its name from. So don't be confused by the fact that it says arachidonic acid, meaning, oh, acids cause damage, which is what you're saying, right? It's not referring to acidity or pH. It's referring to an acid group on the carbon molecule. But what you need to know is its original derivation is a phospholipid. It comes out of the membrane of the cell, okay? So you take a phospholipid and you kind of cut it up and you make a carbon molecule that has an acid group on it, and that's called arachidonic acid. Does that help? Okay. Okay, complement. These guys assist inflammation. These guys assist inflammation. And so what I want you guys to focus on is not so much the three different pathways. Know that there are three, but they all converge. They all three converge onto the C3b. And when C3b is deposited on a microbe, right, you actually get three different opportunities that can take place. C3b can recruit C3a or C5a, and this recruits macrophages, and they ingest the microbe. C3b can actually bind and cause recognition of a phagocyte to ingest the microbe directly, or C3b can actually recruit other complement proteins and form what we call a membrane attack complex. So what is that? This is a complex that inserts various pieces, kind of like, Lego style, and it creates a hole in the membrane of the bacteria, and that causes the cell to lyse, the microbe to lyse. And so by creating this hole, you allow for all of these fluids to enter, and it bursts the microbe. Okay? So what I want you to take away from complements is they assist inflammation by getting rid of bacteria. They have three different pathways that can do this, but their role isn't direct. Their role is a complementary role, okay, in inflammation. So Last slide before this summary slide that I keep talking about, plasma mediators. So kinin and coagulation system. So we referenced this previously. You learned about, at least you learned about the coagulation system in 202 when we talked about blood. And so you've got factor 12, which is Hagman factor. Factor 12 goes to 12A, and then 12A facilitates 11 to 11A, 10 to 10A, so on and so forth, until you get down to taking fibrinogen to fibrin and then making a clot. So Hagman factor is one of our plasma mediators, otherwise known as factor 12, has a role in inflammation because it helps with margination. You guys remember that? It helps with margination by controlling the viscosity of the blood to allow for cells to move to the edge. And the kinin system utilizes the same factor 12A, and if you take the kinin system all the way through, you end up triggering our complement system. And complement system takes C3 to C3A. And C3 to C3A is right in the middle of where all of these pathways converge as plasma mediators. Okay? Okay, so in summary, from this little section, and then we're not done yet. We got a little bit more to go. We've got vasoactive amines, eicosanoids, complement, and kinin and coagulation pathways. Okay? The vasoactive amines, serotonin and histamine. These guys help to stimulate vasodilation and increase in vascular permeability within the targeted tissue region of inflammation. Serotonin also has a role in assisting factor 12 or Hagman factor in triggering a controlled coagulation. Our eicosanoids that are derived from the phospholipid with an intermediate of arachidonic acid. There's 4 families that have vasoactive effects and help to trigger chemotaxis of the cell to the area of interest. Bronchiospasms on the list, for the sake of completeness, it doesn't have a role in inflammation. It's just another one of the effects of this particular compound. Okay, so why is it there? Well, because some of the eicosanoids do cause bronchiospasm. I kind of brushed over that on that slide. I don't want to focus on it, but I also don't want you guys getting confused when you read about it later. It doesn't have a role here. There's a lot of molecules that do multiple things in the body, right? Like norepinephrine, for example. Okay, complement. Increases capillary permeability, causes vasodilation, triggers leukocyte activation, adhesion, and chemotaxis, and facilitates phagocytosis. And then lastly, kinin and coagulation pathways play into controlling blood clotting. Questions? Okay. That summarizes acute inflammation. Chronic inflammation is actually quite simple now that we have that background, because chronic inflammation is everything we just talked about plus. And the plus is time. So with chronic inflammation, things go on for a much longer period of time. So here's acute on the left, and then here's chronic on the right. And I've kind of alluded to this, where with chronic, you see the neutrophils come up and come down. The macrophages come up, but they stay elevated. And here we see that inflammation as a whole comes up and comes down, but over in chronic, inflammation comes up and it stays elevated. And then we see some other things. We see neovascularization, which refers to new blood formation, new blood cell formation, and these vascular elements stick around because the macrophages are still there. And then we see macrophages fusing together, forming what we call foreign body giant cells. This is where, like that cobalt chromium hip, you get a macrophage trying to digest it and it's too big. The macrophages will link together and they'll fuse. They'll actually form a multinucleated giant cell. And these foreign body giant cells are multinucleated, meaning they're like 20 macrophages that fused and created a giant macrophage, and that's what they're called. Fibrosis goes up, and this persists in these chronic diseases for years. So, hematoxylin and eosin example, this is lung tissue. And this lung tissue is showing on the top is chronic inflammation. You've got a collection of inflammatory cells here with the yellow asterisk. We've got these arrows that are showing fibrosis that's taking place. We've got the arrowheads that are showing cuboidal epithelium that has been metaplastically replacing simple squamous epithelium. And in contrast, we've got acute inflammation of the lungs down low, where you can appreciate the vascular networks here that are vasodilating and allowing for all the cellular infiltrate to come out, but you don't have a dense collection of cells here. Here's actually a foreign body giant cell right down here, which isn't actually labeled, but that's another sign. I'll show you better pictures of a foreign body giant cell here in just like 2 slides. So with chronic inflammation, we get this inflammation infiltrate that takes place that's mostly these macrophages that are persisting. We get a lot of tissue damage. We have aggressive angiogenesis because those macrophages are still around. And we have a tremendous amount of scarring that takes place. Now, this should all make sense based upon some of the roles and activities of the cells that we know that are present. So what we've learned about is this macrophage, and we haven't learned about these T lymphocytes quite yet. So we're going to kind of ignore those for now, but we're just going to reference them. The macrophage itself becomes activated. This activated macrophage triggers all these inflammation pathways, and it also presents antigens to the lymphocyte pathway. The lymphocyte pathway is part of triggering the immune system. And so in chronic inflammation, our immune system is now involved, like our adaptive immune system. And we'll talk more about the adaptive immune system in a couple of weeks, but understand that the macrophage plays a huge role because it is present for the entire time. So our neutrophils, like we keep saying, are the first cells that show up after the fluid comes in. Macrophages show up next, second responders, and they stay elevated chronically. So this particular granuloma really characterizes what happens in chronic inflammation. And so we've got this chronic inflammation that's happening right in the middle of the slide. Do you see all these foreign body giant cells on the periphery? So those are multinucleated, and they're huge. And this walls off this inflammation from the rest of the body. And you form a capsule, what we call a fibrous capsule. So this fibrous capsule is isolating the chronic inflammation from the rest of the body. So some of the telltale signs of chronic inflammation are, let's name them. You guys name them. What's that? No, just signs histologically of chronic inflammation. Giant cells, presence of giant cells. What else? Collection of neutrophils could be. Usually it's giant cells. The neutrophils come up and go down, and usually macrophages come in next. So I'd say macrophages over neutrophils. Foreign body giant cells for sure. A fibrous capsule that walls it off. Okay. Another name for these giant cells is epithelioid cells. So you might see that in certain textbooks. Let me show you this example, and this is the last slide. So this is a medical device that's implanted. It's a vicryl material that's a common material. They make suture out of it. They make hernia patches out of it, and it's dramatically inflammatory. And so the polypropylene on the left is control, and you can see foreign body giant cells, all the purple dots, and some of them are multinucleated where the red arrows are. And then this is work that we did. We actually created a covering or a coating, a matrix coating over this polypropylene to try to reduce the level of inflammation. And so you can see on the right the same material with our coating and the level of inflammation subsiding histologically. Can you guys see the difference? So you can see that there's still maybe one foreign body giant cell here, but not nearly as many as all that are surrounding in these red arrows. All the red arrows are foreign body giant cells. So when you have a hip implant, when you have a stent or a stent graft put in, if you have screws or plates or any kind of foreign object in the body, your body sees it and creates chronic inflammation around it. And so what a lot of medical device manufacturers do is they try to use materials that are more biocompatible, where they take non-friendly materials, coat them, and then make something that's more bio-friendly. And the way that we measure how friendly or how non-friendly a material is by measuring the amount of inflammation. Okay? So, acute versus chronic inflammation. Now, there's a whole bunch of slides at the end. That's extra material, more on this study if you're interested. But it's not necessarily testable material. It's just there if you're interested in learning more. Okay? So, that wraps up acute and chronic inflammation, and I'll see you guys on Monday. Hey.
So, like, say if
Oh, let me turn this off real quick. Here, one second.